Hello Health on LAE is presented by the Ochsner Health System, a nonprofit, academic, multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 7 hospitals and more than 35 health centers located throughout Southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health finance and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with LAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topics: irregular heartbeats and the devices that can get our hearts back in sync. Tonight's guest is Dr. Daniel Morin. In the second half hour of our program, we're going to be taking your questions live by phone at 504-866-3200. That's 504-866-3200. And we'll be taking your emails tonight. Just email your questions to hhquestions@wlae.com. Well, Dr. Morin received his medical degree from the University of Massachusetts Medical School. He got his Master of Public Health at Harvard. He completed his internship and residency at Tufts New England Medical Center in Boston. And he did 2 fellowships in cardiovascular disease and cardiac electrophysiology at New York Presbyterian Hospital's Weill Cornell Medical Center in New York City. He is board certified in internal medicine, cardiology, and clinical cardiac electrophysiology, and it is our pleasure to welcome cardiac electrophysiologist Dan Morin to Hello Health. Nice to have you with us on the program.
Thanks, Tom. It's a pleasure to be here.
Well, tell us how you got interested in medicine and how you ended up in New Orleans.
Well, in terms of how I got interested in medicine, when I was a little boy, I was always going to be, some form of scientist or a doctor or something along those lines. My mother's a nurse. My father was an engineer. So it was always going to be one of those things. I always had a chemistry set when I was a kid. When I was in high school, I was in a terrible car accident. And watching the doctors and the nurses and the other professionals help me to get back to being strong again really made the difference for me and got me into medicine more and more. As I became more aware of the different parts of the heart, like different parts of the body, including the heart was the most interesting to me, and that's why I became a cardiologist and ultimately an electrophysiologist, which we'll talk about in a little bit.
You are married to a teacher, but you felt it was also important for you as a physician to continue to teach, and that's one of the other reasons you ended up here in this city.
That's right. I love to teach. I also like to do research, and that's really what landed me in my job at Ochsner, which affords me the ability to do all of those things.
Okay. From the Boston area originally?
That's right.
Okay. Well, some of our viewers may never have heard of electrophysiology, so let's start with a definition. What is it?
Okay. Well, most people have heard of cardiology, which is the study of the heart. Electrophysiology is a subspecialty within cardiology where we specialize in the rhythm of the heart, which is controlled by the electricity of the heart, and that's where the word electrophysiology comes from.
Okay, we're going to show the people this picture in a moment as we talk in greater detail. What are some of the problems electrophysiologists deal with?
So as I said, the electrical system of the heart takes care of the rhythm and the rate of the heart. So any of the problems that have to do with the rhythm or the rate of the heart is really in our purview. Some of the problems that we deal with there are many of them, but some of the ones that we're going to talk about today include slow heartbeats, fast heartbeats, and uncoordinated heartbeats.
Okay. How does the electricity in the heart normally work?
Well, let's take a look at that picture that we were just seeing just a moment ago, which is a picture of the heart with its electrical system inside it. Now, the normal heartbeat starts in the top of the heart in this small structure in the top left that's called the SA node. Now, that's the normal or native pacemaker cell that everybody is born with. And that little cell puts out electricity about once per second, and it spreads across the top chambers of the heart. Whenever the electricity goes across the top chambers of the heart, it makes those top chambers squeeze. The electricity then spreads across the bottom chambers of the heart, and it makes those squeeze. So you get the top one squeezing and then the bottom one squeezing. It goes bum, 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 and that's how you get a heartbeat.
Okay. Let's talk about slow heartbeats first. What kinds of problems can a slow heartbeat cause?
Well, a slow heartbeat can come about from a number of different reasons. One might be that SA node, the normal pacemaker cell of the heart, just slows down. Another reason might be that the top chamber of the heart can't talk to the bottom chamber of the heart. That's a condition called heart block. Those things can both occur as a result of medications, as a result of just getting older, or from, in some cases, a heart attack. So this is one example of a heartbeat that we have up here on our screen. This is an EKG, which again, as you may know, records the heart's rate and rhythm and the electricity that's going through it. Let's take a look at the components of an EKG. Over there on the left, the first beat, you see the P wave, which is the very small height sort of bump, and that correlates with the squeezing of the top chamber of the heart. Next comes the R wave, which sort of looks like a spike. That correlates with the squeezing of the bottom chamber of the heart. The T wave is sort of the reset button. So you get the top part, the bottom part, and then the reset. And so that's what's happening on this left side of the screen. This person has 3 normal beats: top part, bottom part, reset, top part, bottom part, reset, top part, bottom part, reset, and then we see the top part beating. That is a small P wave, but where that arrow is, we see that there's a lack of an R wave in that case. So the top chamber of the heart has failed to talk to the bottom chamber of the heart. When the bottom chamber of the heart doesn't get the message from the top, it doesn't beat, and therefore causes a pause in between the beats of the bottom chamber of the heart.
Okay, so that's a slow heartbeat, and let's stay with this for a moment because you're going to tell us how someone with a slow heartbeat feels.
Right. So with a slow heartbeat, of course, the heart's purpose is to move blood around the body and get it up to the brain. Now, if the heart is going too slowly, it's not moving enough blood. So if not enough blood or fuel is getting around to the different parts of the body and to the brain, that patient can feel tired or run down. They can feel like they get out of breath when they walk across a room or sometimes while they're just still. They can feel dizzy or lightheaded, or sometimes they can even pass out if the pause is long enough.
In some cases, you have just described someone who's out of shape, but oftentimes people in the best of shape, marathon runners and others, will have slow heartbeats. So in some cases, that is a normal pace. A slower heartbeat is a normal pace. How slow is too slow in the dangerous area?
So a normal heartbeat for the average person is somewhere between 60 and 100 beats per minute. That's normal for a person at rest. As you said, sometimes highly trained athletes can have a much slower heart rate. The example that I often use is Lance Armstrong, the famous biker. And his resting heart rate is around 42 beats a minute is what I hear. That's normal for him. He's a highly trained athlete. But it's not normal for the average person off the side of the road. So really, when a heartbeat is slow and that person has symptoms that go along with that slow heartbeat, that's when that heartbeat is too slow. Also, almost always a heartbeat while at rest, while awake, if the heartbeat is less than 40 beats a minute, it's almost always abnormal.
Okay. What are some of the treatment options for someone with a slow heartbeat?
Well, first we want to be sure that there's no easily reversible cause of a slow heartbeat. And as we talked about before, one of those easily reversible causes might be the medications that the patient is taking. A lot of patients take beta blocker medications or calcium channel blocker medications, which are excellent medications, and we use them very frequently. But one of the side effects, or one of the effects of those medications, is to make the heartbeat go slower. So there might be an option that we can either reduce the dose of that medication or change to a different medication altogether. Sometimes we can't make those changes, however, and sometimes those patients need those medications, and sometimes people have slow heartbeats even in the absence of those medications. So usually when that's the case, we go on to a pacemaker, which is a small device. We can show the picture of a pacemaker. This is a picture of a pacemaker here. We see that's implanted in usually the left upper chest area. It has some wires that come out of it and go into the blood vessel that lives underneath the collarbone. You can see those wires in blue going down the blood vessel and into the heart, usually one wire into the top chamber of the heart and one wire into the bottom chamber of the heart.
What you don't see there is the scale of what a pacemaker looks like, but fortunately you have brought along something to show us.
I have brought some pacemakers with us today. I have them here in my hand, if you can zoom in on those. They're not very big. You see that they're metallic boxes, and those metallic boxes contain a battery, which actually takes up most of the device, and a small but very sophisticated computer. Those components are then connected to a wire through these holes that are in the side. I'm not sure you can see this exactly, but there's holes here on the side, and those are connected to the wires, and the wires go into the heart, and that's how the pacemaker knows what's happening inside the heart.
Okay, a pacemaker, is it always, it's always on, but is it always working? Is it always functioning, or just when it needs to?
It's just when it needs to. The only thing a pacemaker does is to take care of the heartbeat when it's too slow. If the heartbeat is fast enough, the pacemaker does nothing at all. It just sits there and watches. But if the heartbeat goes too slowly, the pacemaker puts out a small electrical impulse that the patient doesn't feel and makes the heart beat.
You said these devices have quite a memory inside of them. What is the use of the memory inside of them, and how is that helpful? What is it memorizing?
So these devices can know what the average heartbeat is for the patient over the time. A more complex device like an ICD, which we'll talk about a little bit later, a defibrillator, has information about bad fast heart rhythms that allow us as doctors to figure out what caused the rhythm and how we can fix it so it doesn't happen in the future.
Are these in any way tailor-made to a particular patient? Are they remembering anything about the individual patient?
They're all very controllable and programmable, so you can turn on some memory features and other memory features not. Some of the times when we shut off some of the memory features, the battery is preserved for a longer period of time. So we always have to weigh information versus longevity for these devices.
Are you the person, as a cardiac electrophysiologist, who actually puts this into someone?
I am. It was a major part of my training to learn how to use these devices properly, how to implant them safely and effectively.
Okay. Tell us how you do that. What is the surgery like, and where is it implanted in the body?
Okay. So this requires a one-day hospital stay. It's a minimally invasive surgery that we do under moderate sedation. We bring the patient into our operating room, which we call a laboratory sometimes. We numb them up in their shoulder, usually their left shoulder, and we make a tiny incision where the device goes into. And the device goes just underneath the skin. We use a needle to get into that blood vessel that lives underneath the collarbone, and we use that blood vessel to tunnel the wire or the lead down into the heart, usually one wire into the top chamber of the heart and one into the bottom chamber of the heart. Then those wires are connected to the pacemaker, and the pacemaker is slipped under the skin, just underneath the skin, not inside the thorax or the chest wall cavity. We sew the incision closed, and the patient spends one night in the hospital with us, usually go home the next day.
So while you're touching the heart with the wires, this isn't open heart surgery in any way?
That's right, it's not. In order to drive these wires into the heart and to put them into proper locations, we use sort of X-ray movies in order to see where the wires are going.
Okay. We've talked about slow heartbeats, so now let's talk about fast heartbeats.
Sure. So fast heartbeats can range tremendously from moderately worrisome or problematic, or to not problematic at all, to extremely dangerous. Some forms of fast heartbeats just cause palpitations or feeling your heartbeat fast and uncomfortably. Other heartbeats that are fast aren't felt at all, believe it or not, even when patients' heartbeats are really quite fast. And then there's others that are quite dangerous. Let's take a look at one of those one of those very dangerous fast heartbeats.
Show people the EKG again, right?
Sure. So this is the EKG that we saw earlier. And remember, earlier we had on the left side of the EKG that the patient was doing fine. Well, on this EKG, the patient is doing fine as well. You can see those R-wave spikes. Those are those tall spikes that are coming at a normal rate on the left side of this EKG. So that patient's heartbeat is going bump, 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 like it's supposed to. But as we get to the right side of the screen, suddenly we're going very, very fast. These are the kinds of tracings that you see on television, doctor, and medical shows, where everybody doesn't like what they see. This is a rhythm called ventricular tachycardia. So instead of the heartbeat going bump, 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 suddenly it's going bump, 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 bump. And when it's going that fast, it's not moving the heart is not moving blood very efficiently at all. Under those circumstances, oftentimes the patient passes out. And if not treated very quickly, you can progress to the rhythm that we see on the bottom EKG, sort of the darker one. That's called ventricular fibrillation, and that's even more dangerous.
Okay. I'm watching the women's soccer match, and there's a minute to play, and I'm nervous, just like everyone else watching. What is my heart doing, and is that normal? And I think I said in inviting people to watch this program, when you're in love, sometimes the heart is going to move faster. So sometimes a normal walking up a flight of stairs, a faster paced heart is perfectly normal, right?
That's right. And under those circumstances, we're still seeing the same pattern of the heart beating. The top chamber of the heart is beating, it's going bump, and then the bottom chamber of the heart is going bump right after it. So it's bump, 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 just a lot faster than that. But in this case, here, the ventricle, or the bottom chamber of the heart, is just going tremendously, tremendously fast, out of sync with the top chamber of the heart, and that is what really causes the problem.
Okay, we talked about how people might feel with a slow heartbeat. How might people with a irregular fast heartbeat feel?
So patients with a irregular fast heartbeat might range in symptoms from not feeling anything at all. That's frankly relatively uncommon. They can feel palpitations in their heart. That's just feeling their heartbeat abnormally. Sometimes it can make people feel lightheaded or dizzy. It can make them pass out. And under severe circumstances, it can cause death if not treated very quickly.
Have you heard of someone coughing to get their heart back in rhythm?
I have heard that. I've actually asked patients to cough to get their heart back into rhythm.
So it does work on occasion?
It does work on occasion.
What's happening physiologically that would trigger that?
When you're coughing, you're increasing the pressure inside your lungs and therefore increasing the pressure of the blood flow to the heart. And you're causing a change in the electrical activity inside the heart that can sometimes be just enough to get them out of the bad rhythm.
Okay, we're going to talk about cardiac arrest in a moment. You would not recommend people start coughing to get themselves out of cardiac arrest.
That can sometimes be useful. Sometimes if you don't have the proper equipment around, if you see someone immediately have cardiac arrest, only if you're a trained professional, what's called precordial thump can be useful, an actual blow to the chest wall.
Okay, but go get help right after that. Don't
go get help first if you are not a trained professional.
Okay. Are all fast heartbeats dangerous? We touched on that earlier.
So not all heartbeats, fast heartbeats, are dangerous. Sometimes they just cause palpitations. Sometimes they don't cause symptoms at all. But other fast heartbeats can be extremely dangerous.
Okay. Let's show people what a sudden cardiac arrest looks like, again, on an EKG. So let's look at this.
So this is the most bad, or the worst case of bad fast heart rhythm. This is sudden cardiac arrest. And again, on this EKG, on that top strip, you can see at the beginning, that means the left side of the EKG, that person's heartbeat is sort of going a regular rate, a normal rate. But then suddenly, that patient develops at 6:02 in the morning a bad fast heart rhythm. This was a patient in the hospital. A bad fast heart rhythm called ventricular tachycardia. That continues to 6:05, and then by 6:07 they have developed a different rhythm called ventricular fibrillation, which is even more dangerous. And then even by 6:11, which is only 9 minutes after the onset of this arrhythmia or bad rhythm, this patient has a flat line tracing on their EKG, and that indicates that there's no electricity going on in the heart at all, and there's no heart beating happening at all. So you can see that in just 9 minutes, this is important for our viewers to recognize that in just 9 minutes, this patient has gone from a normal heartbeat to no heartbeat at all. So it can be very quick.
Is sudden cardiac arrest a common problem in this country?
Unfortunately, it's a very common problem. We'll see here on our list of leading causes of death in the United States, a lot of the things that people think about. You know, looking down on the bottom, we're talking about cancer as a cause of death, stroke, emphysema, diabetes, infections, accidents, things along those lines. But I'd like to focus, of course, here on the red line, which is second to the bottom, and that is showing that sudden cardiac arrest is a very, very common cause of death, second only to all cancers in terms of total numbers of lives lost. Each year, about 400,000 people lose their life to sudden cardiac arrest.
Who is at the highest risk for sudden cardiac arrest?
Well, the number one risk factor is having a prior sudden cardiac arrest. Someone who has previously had a sudden cardiac arrest is at very, very high risk for having another one in the future. People who haven't had a sudden cardiac arrest, there are also risk factors that we know about for those patients. One of the ones that we use most often is a low pumping function of the heart, which is called the ejection fraction. Another is having had a prior heart attack. And lastly, having had a family history of sudden cardiac arrest.
I don't see obesity listed there, and I'm surprised I don't.
Obesity does go along with some other risk factors, certainly with coronary artery disease, therefore heart attacks, diabetes as well, which can lead to coronary artery disease. But obesity in itself is not a risk factor, or at least not a major risk factor for sudden cardiac arrest.
Okay. People at home may be saying, is sudden cardiac arrest the same thing as a heart attack? And the answer is no.
The answer is no. They're really as different as apples and oranges. A heart attack comes about because of blockages in the arteries that feed the heart with blood. Suddenly there's a blockage there and blood is not getting to the heart. That, of course, causes chest pain and a heart attack. In contrast, sudden cardiac arrest is an electrical problem where the electricity of the heart has an issue and the heart's pumping function stops completely. Usually that person just passes right out, and that's the first manifestation without a warning.
Okay. Is the baby aspirin I take every morning going to help me? I'm told by my cardiologist it's going to help me prevent a heart attack, but is it going to help in the prevention of sudden cardiac arrest?
It won't, only indirectly by preventing you, hopefully, from having a heart attack.
Okay. I know one way you measure the heart is what you just referred to, something called the ejection fraction. So what is EF and how does it help in determining risk?
So the ejection fraction is a measurement of the squeezing function of the bottom chamber of the heart, specifically the bottom left chamber of the heart, which is the main chamber that squeezes blood from the heart out to the body. When there's a nice vigorous squeeze, that patient is at lower risk for sudden cardiac arrest. But as that squeeze gets weaker, that patient is at higher risk. A normal ejection fraction is 55 to 65% of the blood that's contained within the ventricle with each beat. In contrast, a low ejection fraction is less than 40%, gets ejected out each time, and sometimes it can be much, much lower than that. Here we have a couple pictures of two patients. These are going to be movies. We'll activate them in just a moment. But the patient on the left is going, and the movie that we're going to show first, will be a patient with a normal ejection fraction, whereas the patient on the right is a patient with a low ejection fraction.
Okay, let's show the first movie now if we can. And again, this would be the beating of a normal heart, correct?
That's right. That's right. So let me orient. Unfortunately, I can't point for you, but you can see here this is a normal heart that's beating inside someone's chest. You can see it looks like two sideways figure eights that are lying down. The left ventricle is the upper portion of the lower figure eight, if that makes sense to you. You can see here that this person's left ventricle is squeezing very, very strongly. Here, the ejection fraction is around 60%. That's normal.
Okay. Let's show people what an abnormal heart looks like in the second video that we brought along.
Okay, great.
Okay. Again, looking in that same spot, right?
Right. So this is the same orientation of the heart with the two figure eights, and we're looking at the topmost of the bottom figure eight. And you can see here that this is squeezing much, much weaker, much less strongly, so to speak. Here, the ejection fraction, or squeezing function of that lower chamber of the heart, which here is higher on the picture, is only 10%. That puts the patient at much higher risk for sudden cardiac arrest.
When we were first watching these, I said, yeah, you can see one is moving slower than the other, and you said, really, it's not how fast, it's how efficient, right?
It's not only how fast, and it's definitely not how fast. It's not only how efficient, but more specifically, it's how vigorously it is able to pump.
Okay. Can you use your hands, if you would, and kind of show me what you're talking about? Because I know you wanted to give us another example.
Yeah, and we'll use hands a little bit later as well when we're talking about cardiac resynchronization. So here, if this is the entire left ventricle, you want it to be squeezing nice and vigorously and ejecting the blood out to the heart. So when it's squeezing nice and vigorously, that's a normal ejection fraction. In a patient with a low ejection fraction, it's not squeezing as vigorously, it's squeezing just a little bit. And that is not only not moving blood well and making the patient feel worse, but it's also putting them at higher risk for developing sudden cardiac arrest, which can lead, of course, to sudden death.
Okay. I was going to say, what happens with one of these bad rhythms, and as you just showed us in the one where we had the 3 different versions, bad to worse, right?
Right.
It can lead to death. Oftentimes
it does. If patients develop these very bad fast rhythms called ventricular tachycardia and ventricular fibrillation, the survival rate for that is dismal if not treated immediately. Usually 95% of those patients don't survive.
Okay. You brought another graph to show us on showing us the importance of getting this treated as soon as possible.
I did. So it's very, very important to treat these patients just as quickly as possible. If we can show the graph, this is a graph of time on the bottom versus percent survival over on the left side. And you can see that if time 0 is the development of these bad rhythms, if you treat this patient immediately, properly, their survival rate is greater than 90%, very, very high. But if the rhythm lasts as long as it did in our other example, only 9 minutes, very quickly the survival rate, even if given the proper treatment, plummets down to less than 10% after only 9 minutes.
In that way, it would be similar to a stroke. The quicker the treatment, the more likelihood for the better outcome.
That's true. We use terms in cardiology and in neurology that time is heart and time is brain, and that's true.
How is sudden cardiac arrest treated today?
Well, back in 1947 at Case Western University, some very smart cardiologists came up with the idea that if sudden cardiac arrest is an electrical problem, well, it may have an electrical solution. And that's why we came up, well, not we, this was well before my time. That's why they came up with the external cardiac defibrillator, and that's the device that you see on television, doctor, and nurse medical shows of patients getting shocked with when they have a code or a bad, fast rhythm. One example of that is seen on the EKG on the bottom. You see here that in contrast to our patients on the EKGs that we saw earlier, where they were doing fine at the beginning of the tracing, this patient is doing very poorly. This patient has ventricular fibrillation, which is a deadly rhythm. Then we see the vertical sort of line there. That's the electrical shock that has been delivered from this external defibrillator that then results in normal rhythm and saves this person's life.
That were sometimes referred to as paddles, right?
Exactly. So the paddles are connected to the box.
Okay. The paddles always work, and if not, why not?
They don't always work, but they are very, very effective, especially if delivered in appropriate amount of time. Okay. Sometimes the problem with the cardiac arrest is not a primary electrical problem. Maybe something else caused the electrical problem to happen. And if you don't solve that original problem, no amount of shocking is going to help.
What if there's no one around to rescue you, or there's not one of these defibrillators nearby?
So that's really important. I oftentimes tell my patients who are at risk for sudden cardiac arrest, or those patients who have had sudden cardiac arrest, that I would really like to follow them around with one of those defibrillators. But I can't do that. It's heavy and there's too many patients. But what I can do is offer them an automatic implantable cardioverter defibrillator, or an ICD. That's a picture that we're seeing here. And you can see that it looks a lot like, at least on this picture, it looks a lot like a pacemaker. It's made out of a metallic box. It's got wires connected to it, and those wires go down into the heart. I have some real defibrillators with me here today, if you want to show those. They're a little bit bigger than the pacemakers, and that's because they do more things than just the pacemakers. All defibrillators nowadays have pacemaker function, but in addition, they're able to automatically detect these bad, fast rhythms and to deliver a large shock from within automatically with nobody else helping, no matter where you are.
Very good. We've talked about fast heartbeats and slow heartbeats, and now we want to focus on uncoordinated heartbeats. How can you tell if a patient's heartbeat is uncoordinated, and is this a dangerous condition?
Well, a patient with an uncoordinated heartbeat, of course, the main purpose of the heart is to move blood around. If a heartbeat is uncoordinated, and I can show that again with my hands, if a patient, what you want is for the heart to beat in a coordinated fashion, all of the walls coming in at the same time, coming in and moving the blood out, moving it out to the brain, to the body, supplying oxygen and nutrients to the body and to the brain. Sometimes, though, the walls aren't working at the same time. So maybe the right one comes in first and the left one comes in afterwards. So now, instead of moving the blood out like you're supposed to, now you're sort of sloshing the blood back and forth. This is an uncoordinated heartbeat, not moving the blood around. And just as when we were talking about earlier with a slow heartbeat, if you're not moving enough blood around, that patient can feel short of breath, tired. They can pass out under some circumstances, though usually not with an uncoordinated heartbeat.
You would treat a condition like this, or one way might be with a cardiac resynchronization therapy device, sometimes referred to as a CRT. Let's show people what that looks like and how does it work.
Sure. So we'll see up here on the screen two different pictures. One on the right is a picture of a regular ICD that we saw earlier with the two wires, one going to the top right chamber of the heart and one going to the bottom right chamber of the heart. That's a sort of a normal non-CRT defibrillator. On the left side is a CRT device, and you can see the chief difference here is that in addition to having a wire on the bottom right side of the heart, you in addition have one on the bottom left side of the heart. So that now, if the problem was, if I can show my hands again, if the problem was that first the right was coming in, and then the left was coming in, here we go. Yeah, so if first the right is coming in and then the left is coming in, well, if I pace the right, I can pace the right all day long and I'm not doing anything to help the left side. But if I put a wire over here on the left side of the heart, like we saw in that picture, now I can pace both sides of the heart, and we're back to resynchronizing and being able to move the blood out in the way that it's supposed to go.
And the wires, you've talked about connecting the wires. So I had one question.
Mm-hmm.
How big are the wires, which you're going to show us right here?
Sure.
Also, how do you physically connect? Is it with a suture that you connect the wire to the heart itself?
Well, that's a great question. So this is a pacemaker wire. You can see it's fairly thin. It's maybe, I don't know, 2 millimeters in diameter here.
Mm-hmm.
And
I'll hold
this
my
wire,
pen up next to it and give you an idea there, too.
Sure. So this wire, as we were talking about, is threaded through the blood vessel, if I can show on myself, through the blood vessel in the top shoulder, and then down into the heart this way, such that it's down here, and it comes into contact with the heart on the inside. Then
how is it attached to the heart?
Well, that's a great question. Sometimes there are these, I don't know if you can get in close enough to see this.
Hold it still for us. There
I
you
will.
Go.
Sometimes this is called a passive fixation lead that has sort of these little tines at the very tip of it. And that just grabs onto the inner portion of the heart, which is sort of rough in surface, and then this thing grabs on like a grappling hook. Okay, that's one way that we fix them in. Another way that we can affix them, and this might be difficult to see as well, but this is an active fixation lead where if I screw here, these are the two ends of the lead. If I screw here on this end, which is again outside the patient, it extends a small helix or a screw right there at the tip of it, so it actually screws right into the heart muscle inside.
That's where that engineering comes into handy. You talked about as a child.
Yeah.
Well, our guest is Dr. Daniel Morin, and tonight we're talking about irregular heartbeats and sometimes dangerous heartbeats and the devices that can make our hearts work more efficiently and perhaps even save our lives. Our phone number tonight, 504-866-3200, 866-3200. You can call right now with your questions, or you can email us your questions at hhquestions@wlae.com. I'm going to ask the doctor one more question. We're going to take a break and then come back with your questions. What's more dangerous, a slow heartbeat, a fast heartbeat, or an uncoordinated heartbeat? Or is it that simple?
Well, I wish it were that simple. It's not really quite that simple. I think we learned that most of the time people would agree that certain types of bad, fast heartbeats are the worst. Those are the ones that cause sudden cardiac arrest and, if not treated immediately, sudden death. In contrast, there are other kinds of fast heartbeats that don't cause problems at all, or maybe mild symptoms of palpitations or lightheadedness. And then there are slow heartbeats and uncoordinated heartbeats, which usually affect the quality of life more than the length of patients' lives. So I usually say, treat a bad fast heart rhythm and extend life. Treat a bad slow heart rhythm or treat a bad uncoordinated heart rhythm and improve life.
Okay. The other question I want to ask the doctor, and I'll do that when we come back, is has the technology on these devices changed as such where we don't see the malfunctions that we hear about on occasion or have heard about on occasion? So we'll be asking that question as well. Again, 504-866-3200. That's our phone number. We hope you'll call with your questions right now or email questions, hhquestions@wlae.com. This is Hello Health on LAE, more than television.
I'm Meryl Streep. Can television make a difference in our lives? It does make a difference. Television changes you, so it's important what you watch, when you watch. That's why I support public television, and I hope you will too.
Welcome back to Hello Health on LAE, more than television. Tonight we're visiting with cardiac, help me out again?
Electrophysiologist.
That's right. I'm glad you had to say it the second time. Dan Morin, Dr. Daniel Morin. Great program, and now your questions. Let's start with line one. Pearl is calling us from New Orleans. Pearl, welcome to Hello Health.
Thank you. I have a question. I take Corey and I take Digoxin for the slow heartbeat. Is that too much, or should I be taking both of them?
Well, thanks for your question, Pearl. I would, certainly somebody has given you those medications for a reason, and those are medications that we use very frequently for a variety of different reasons. Can I ask you, do you know why you're taking those medicines?
I've had irregular heartbeats for so long, like 6 or 7 years, and now they are talking about doing a pacemaker. But I just noticed that a pacemaker and a defibrillator is two different things.
They
and
are.
I always thought they was into one, but with you tonight, I noticed they're two different things.
Well, I'm glad I've been able to teach you something. In terms of heart rate control, that is a very important thing, especially in somebody who, like you, has an irregular heartbeat. And it sounds like you may have something called atrial fibrillation. Is that true?
Heart failure. I have heart failure.
Okay.
Go ahead.
All right. Controlling the heart rate is important also in heart failure, especially in patients with atrial fibrillation. And some of those medications that you listed are the ones that we do use. Under some circumstances, we have to use those medications in order to have the best outcome for patients. And then when that occurs and the heartbeat is too slow, sometimes we do put in pacemakers.
Pearl, thank you so much. We appreciate your question. And watching tonight, Gail is next, calling us from New Orleans. Gail, you're on with Dr. Morin. Go right ahead.
Earlier in the program, you talked about passing out and how having a fast or a slow heart rate could be the cause of that. What if you pass out and you realize you have a positive tilt test? How can that affect your heart?
Thanks for your question, ma'am. Gail, a positive tilt test is just what it sounds like. The patient goes and sits on or lays on a tilt table, and the tilt table tilts up. And then we see what happens to the blood pressure under those circumstances. That is testing what's happening to the blood pressure as well as looking at the heart rate. If you passed out from a tilt test, it may or may not have had anything to do with your heart rate at all. Heart rate and blood pressure are two different things and completely separate in many occasions. So I would have to really know more information about what happened to you during your tilt table test. It really, in order to tell you, I would ask that you speak with your cardiologist to review exactly what happened to you during that tilt table test.
Thank you, Gail. We appreciate it. Line 3 next. Elaine calling us from New Orleans tonight. Elaine, you're next on Hello Health.
Yes, doctor. I need to know what is heart regurgitation. My doctor told me I didn't need any medication and didn't have a follow-up, but I was worried about it because I didn't really understand what it was.
New term. We haven't heard it yet tonight.
Gotcha. Well, thanks for your question, Elaine. You may be speaking about regurgitation of the valves inside the heart. Is that the case?
I think so.
Okay. So there are 4 valves inside the heart. Problems with the valves can either be too tight, in which case they're stenotic, or they can be too leaky, in which case they regurgitate. This is not directly related to the issues that we're talking about today, but a regurgitant valve means that it is leaky. That can be either mild. I have a little bit of regurgitation on one of my valves, and I don't have a problem with it. I hope not to. Or it can be a more significant problem, and we can tell the difference based on people's symptoms and on their echocardiogram, which is a picture of their heart.
These are not typically electrical-related problems, right?
It's not. It's a plumbing problem.
Okay. Let's go to Roxanne calling us from Harvey this evening. Roxanne, welcome to Hello Health.
Hi. My question is, I've been diagnosed with neurocardiogenic syncope and have a loop recorder implanted. What is the typical length of time that they keep that recorder implanted and monitored?
Thanks for your question. That's a good question. So a loop recorder is, I didn't bring one today. I was thinking about it. A loop recorder is sort of like a pacemaker that only listens. It's only listening to what the heartbeat is doing. We put loop recorders into patients who have infrequent passing out episodes. And those loop recorders that we can talk to right through the skin, just like we talk to a pacemaker or a defibrillator, those can stay in for 18 months. And they always record what's happening to the heartbeat, such that if the patient then passes out again, well, we can know what their heartbeat was doing at that time.
That's helpful for a physician in diagnosing what the problem might be.
That's exactly right.
Okay. Let's go to Linda calling us from Homa this evening. Linda, welcome to Hello Health.
Hello. I've been diagnosed with arrhythmia since 1998. My cardiologist said it's a benign arrhythmia. I've had an emergency room physician say it's tachycardia. which I don't quite understand the difference. But my real question is this: is the medication I'm on is Inderal, 10 milligrams, and my heart races every day, sometimes at night as well. It wakes me up, and so I understand having a normal low or regular blood pressure. If I take something else, it makes my blood pressure too low. So I'm kind of stuck with Inderal because it works pretty good for me temporarily, but it doesn't last. It's not long lasting. So I have to keep taking maybe a half, several times a day. But I do understand that they're working on maybe some new medication just for arrhythmias that will not affect your blood pressure so much. And your maybe thoughts on the difference in the tachycardia, benign arrhythmia.
Sure. So thanks for your question. So it depends on what type of arrhythmia you have. You describe a medicine called Inderal, which is the trade name for a medicine called propranolol, which is one of the beta blocker medications whose job is to sort of calm down the heart's beating or automaticity of the heart. Depending on what your arrhythmia is, it's difficult for me to say without seeing your EKG. I trust that you've seen a cardiologist about this, and hopefully you've captured some of these episodes, which is really the critical thing. When people have a tachycardia or an arrhythmia, we need to know if it's one of these ones that is very dangerous or if it's one of the ones that is not dangerous. The best way for us to know is to either put a monitor on to people or in some ways, sometimes we have to do more invasive testing in order to see if we can make the heart have those bad rhythms.
Okay, let's go from the river parishes to the North Shore. Teresa in Slidell, you're on line 6. Welcome to Hello Health.
Hello.
Hi.
My question is, my daughter is 20, and she's been getting like the heart palpitations, the real fast rhythm. I did bring it. She started freshman year in college with it, and she's danced all her life, and she's never had that before. And so we went to the cardiologist. He took a stress test on her and all, and he did not find any heart disease there, he said. So he suggested she get off of caffeine and everything, and she just had an episode yesterday. And what happened was she was at work, and she said it just starts beating, like you could actually see it in her neck, and you could feel it in her chest. And she said yesterday it lasted like an hour and a half because she was at work. She couldn't lay down and rest. So my question is, and it doesn't happen a lot, but she said one time it lasted like 3 hours. Sometimes it'll last 15 minutes.
Boy.
But the cardiologist said, if it continues, and she found after she got off the caffeine it happened less. So my question is, he said like if it keeps happening, we have to go back and have to do more tests on her. But I just don't know if I should be really concerned or like bring it to the emergency room when that happens.
Well, Teresa, it sounds like your daughter is having some concerning symptoms for her. It does sound like it's been going on for a long time, so it doesn't seem like it's one of these bad, fast heart rhythms. It might be one of the sort of annoying heart rhythms, which can sometimes progress to be more dangerous as time goes on. The stress test that was done by your cardiologist, what a stress test does is it's looking for parts of the heart that are having a hard time getting blood. And it's indirectly looking for that. So it's really more of a test for the plumbing of the heart, not as much a test for the electricity or the rhythm of the heart. What it sounds like is we don't have a diagnosis yet for your daughter, but what needs to happen is sort of what I was talking about with the last caller. A monitor needs to be placed so that we can capture one of these episodes and see what the heart rhythm is doing during that time when she's having her palpitations.
And we let viewers know it doesn't have to necessarily be an implantable monitor, which you've described earlier. There are ones you can just wear on your shoulder, right? I've worn one myself.
That's right. So we have some that people wear for 24 hours or 48 hours, and we have others called event monitors that people wear for a month-long period.
Okay. Let's go to Cheryl calling us in River Ridge. Back to line 1. Cheryl, you're on with Dr. Daniel Morin. Go ahead.
Hi. My name is Cheryl, and I was wondering, I have had ventricular fibrillation in March, and I have a defibrillator in me, and I was wondering, I have also a cancer patient, and I'd like to know if it was the chemo or the radiation that caused this.
So that's hard to know, Cheryl. So first of all, I'm sorry to hear about your cardiac arrest, but thank goodness you have a defibrillator now, and I hope that your cancer treatment is going well. Usually, radiation is not the culprit for a depressed ejection fraction, but some kinds of chemotherapy can, under some circumstances, cause damage to the heart muscle itself and cause the ejection fraction to go lower. So of those two choices, I would say that the chemotherapy is much more likely to have caused the lower ejection fraction and therefore your cardiac arrest.
Back to the North Shore where Barbara is holding on line 2. Barbara in Slidell, you're next.
Yes, thank you very much. Appreciate you being here, Doctor.
Thank you.
I was told a year ago that I had an irregular heartbeat. I've never had it before, and I don't know whether I should get more checkups or they said it wasn't the kind to worry about. But is it something that might lead to something else? I'm 86, and for 85 years I had a normal heartbeat.
I gotcha. Well, thank goodness for those first 85 years, Barbara. And you're probably still, well, hopefully you're still doing fine. It's hard to know what those doctors meant by an irregular heartbeat. As we've been talking about, an irregular heartbeat could mean any number of a variety of things. I hope that what they told you is true, that it's not one to worry about. But if you're concerned about it, I would revisit that doctor and say, well, what rhythm is it exactly, and do I need to see somebody else about it?
Thank you very much. We have 3 callers left and 3 emails. So, Doctor, we are in the fast-paced version of our program. Let's go to Janice in New Orleans. Janice, quick question. Go right ahead, please.
Hi, yes. I'd like to know those implanted devices, how long do they usually last in a patient before they have to be changed? And also, is there any precautions other than the normal just kind of being careful that a person who has one of those devices should take? Because I know years ago they said you couldn't go around microwaves.
Right. So, Janice, these are 2 questions that I get very, very frequently when I'm talking to patients about these devices. In terms of longevity, these batteries, these devices are made up of primarily battery, and the batteries last a long time. Nowadays, the batteries are lasting somewhere, for a defibrillator, somewhere between 5 and 7 years, and for a pacemaker, between 7 and 9 years. Now, that depends on how often you have to use the pacemaker or defibrillator. Of course, if you get a big shock, it takes a lot of energy out of the battery, and that reduces the lifespan of the device.
What about restrictions when you have these devices?
So in terms of restrictions, there used to be a big problem. These things used to be much more susceptible to what's called electromagnetic radiation or interference from other electrical things. And patients who had these pacemakers or defibrillators wouldn't be able to go next to a microwave, for example. Nowadays, that's not as big of a problem. I usually tell people just don't hug your microwave and you're totally fine.
Arm's length is kind of the distance you give them, right?
Arm's length is totally fine. There are other things that can be problems, like the one-armed bandits at casinos. Or one thing that's a big no-no is if you have a defibrillator, you should not ever be an arc welder, because that defibrillator can detect the arc welding as a bad fast rhythm and deliver a shock that you don't want.
Great questions. Let's go to Jim on line 4 with a quick question. Jim, go right ahead.
Yes, good evening. I had some incidents of heart flutter, and since then have been diagnosed with that and have had an ablation.
Okay.
Some month after that, it was determined that the ablation had not worked entirely, and so right now trying to schedule for another ablation. But I wonder if you could talk about flutter a little bit.
Sure. So flutter is an abnormal rhythm that comes about from the top chamber of your heart. If what you're talking about, Jim, is what I think, and that's called atrial flutter. That usually lives in the top right chamber of the heart, where instead of the electricity coming out of that SA node in the top chamber of the heart and then progressing quickly down to the bottom chamber of the heart. Instead, in atrial flutter, there's a racetrack that lives in the top right chamber of your heart, where the electricity jumps onto that racetrack and goes around and around in that racetrack about 300 times a minute. If that's indeed what you're talking about, ablation is oftentimes a procedure that we use in order to treat that. That's basically electrocautery interrupting that circuit. That is usually about 95% of the time effective, but 5% of the time, it comes back, and you need a second therapy.
Okay. Our last caller is Barbara, calling us from Galliano this evening. Barbara, welcome to Hello Health.
Thank you for taking my call. Would Dr. Morin tell us, please, what is the most common negative effect on the heart and or the most dangerous of high blood pressure?
Sure. So the heart, as you know, Barbara, is a pump. And what does it have to pump against? Well, that's the blood pressure. So the pump has to squeeze hard enough to push the blood out of the heart. And the thing that it's fighting against in order to do that is the blood pressure. So if the blood pressure is high, then that heart has to squeeze harder. And under those circumstances, then the heart muscle has to get bigger and thicker, and that can be dangerous in itself.
Okay, let's get to one email question very quickly. Doctor, what would cause a pacemaker to dip below the program setting? This is a question from Kurt.
Well, Kurt, that would, these pacemakers in general do what we tell them to do. It would be a malfunction of the pacemaker to dip significantly below the lower rate limit, which is the number that we set that we don't want the heart to go below. Now, oftentimes people are at home and they are checking their pulse rate and they know that their pacemaker is set to 60 beats a minute and they get a reading that says 58 or 59 beats a minute. That's just due to measurement error. If you have a pacemaker that you know is set to 60 beats a minute or something like that, and your heart rate is going significantly slower than that, well, you want to be sure to get your pacemaker checked out soon.
Okay. We did receive a couple of other email questions. Unfortunately, we are out of time, but we'll do our best to get those to the doctor, see if we can get you those answers to the questions you have forwarded tonight. And some great questions from our callers and emailers. We want to thank you, and of course we want to thank Dr. Daniel Morin for the education and information he's provided tonight and for his work in the Ochsner Health System. Thanks so much. Great education tonight.
Thank you, Tom.
Okay. Well, here's a preview of what's ahead with Hello Health on TV. Let's take a look. On Monday, July 25th, we'll be back here on LAE with an encore presentation of a program we brought you not too long ago with Dr. Teddy Winstead, returns to discuss irritable bowel syndrome. We'll talk about what causes it and how it is treated. That's coming up on Monday, July 25th. To make an appointment with any of Ochsner's physicians, including tonight's guest, Dr. Daniel Morin, who actually puts the devices in himself, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at this special number, 504-842-5669. That's 842-5669. As a reminder, you can re-watch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Just type Hello Health in the search areas. Our thanks again to tonight's guest. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, LAE, more than television.
Health on LAE has been presented by the Ochsner Health System. 600 physicians in 80 medical specialties working with a team of more than 10,000 employees to provide nationally recognized health care across Southeast Louisiana. Ochsner, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.